My name is Fredah, and today I'm going to talk to you about the Affordable Care Act. This presentation was put together by myself, Iyadunni, Liborio, and Ijeoma of UMUC HCAD 620.
Hello. So let's start by talking about this term, Obamacare. And the term came about because of the political divide in this legislation. And by that I mean that when the legislation was passed, it was passed only with Democrat votes. Not a single Republican voted for this legislation. And when I say this legislation, I'm referring to two different parts. Not four, two different parts. The first part was the Patient Protection and Affordable Care Act, which was signed by President Obama on March 23, 2010. And then 7 days later, an amendment was passed, which they called the Healthcare and Education Reconciliation Act. And that was March 30th, 2010. And again, both of these parts, not a single Republican voted for. So using the term Obamacare really brings in the politics. And so when you want to keep to the facts, using the term Affordable Care Act brings these two parts together in this piece of legislation.
The background of the U.S. healthcare system and the Affordable Care Act is that the U.S. health system is not centralized. It's a very fragmented system with a lot of different groups with different self-interests. And there are many people in the United States who believe that the Affordable Care Act is unconstitutional and ineffective. So there's a lot of debate about this legislation, even now, 4 years after it was passed, or 5 years. The U.S. is a capitalist economy, and as a result, many people believe that this act is a threat to free enterprise. The population of the United States and the healthcare system, there's about 30% that are eligible for Medicaid and the Children's Health Insurance Program, or the CHIP program, 10% who have insurance through small group insurance or individual insurance, 45% who have insurance through mid-size or large employers, and then another 15% who have Medicare. And when you look at the spending with these different groups, about 16% of the spending comes from Medicaid and the uninsured, whereas 38% each for the mid-size or large employer group and Medicare, that's where the spending is allotted. So 38% to the large group and 38% to Medicare. So you see that really the Medicaid group does not spend as much as some might believe.
Now that we've discussed a little bit about the background of the American healthcare system, let's discuss what the Affordable Care Act actually does. So the first thing is it requires states to either set up health insurance exchanges of their own, or it requires that they utilize the federal option. We'll go into that a little bit more in a moment. It includes employer responsibility to give health insurance to its employees if it's got more than 50 people in the company. There was the Medicaid expansion in the original Affordable Care Act, and that was removed by the Supreme Court ruling, another thing we'll go over shortly. It required health insurance plans to meet guidelines for minimum coverage. It established a pilot program to try to bundle payments to physicians in order to remove that fee-for-service that was being done in the past. And then it has the individual mandate requiring people to have insurance. Now that does have some exceptions, and we will go over that as well.
So the health exchanges. Here's some examples of a few different health exchanges. We have, this is the Government Federal Health Exchange. This is California and Maryland, and you can see that even though they all look different, they have a lot in common.
So what are these health insurance exchanges everyone keeps talking about? The insurance exchange is a centralized place for information about the different companies that are selling insurance. And the Department of Health and Human Services describes it as a mechanism for organizing the health insurance marketplace to help consumers and small businesses shop for coverage in a way that permits easy comparison of available health plans based on price, benefits, services, and quality. So it's really supposed to give a lot of information to consumers who might have otherwise just, called a company and said, hey, what do I have? And maybe they might not have known their options. So the competition between the companies may not have been there. It also assists individuals and small businesses to gather information in one place. It's not a new concept. Health exchanges have actually been around for a little while. States like Massachusetts, Utah, and California all had health exchange or this health exchange type of program prior to the Affordable Care Act. In Massachusetts, they called the Massachusetts Health Connector. In Utah, it was the Utah Health Exchange, and in California, it was called PAC Advantage. So in the Affordable Care Act, they have some exchanges that are run by states. All states have the option to run their own health exchange, but if they choose not to, there is the option to utilize the federal health exchange. And if the states do choose to create their own, that has to be approved by the Health and Human Services Secretary to say that this fulfills the requirements of the Affordable Care Act.
So who is newly covered?
Okay, so now let's talk about who's newly covered under the Affordable Care Act. First, people who work for a company that has more than 50 employees, those companies are now required to give health insurance to their employees. So if you're one of those people, congratulations. The next thing is many of us may know kids who perhaps are able to maintain health insurance until they're 25 years old, thanks to the Affordable Care Act. Individuals who are eligible to receive federal or state assistance via tax credits, and these credits are available to families and individuals who make between 133 to 400% of the federal poverty level. If you think about it right now, the federal poverty level is about $19,530 for a family of three. So 133 to 400% of that poverty level are eligible for these tax credits, which again should help a lot of people afford health insurance. Then you've got the removal of pre-existing conditions. As you may know, in the past, a lot of time people were either denied flat out health insurance based on pre-existing conditions, or they were just unable to afford the premiums that came with certain health conditions. So now those people hopefully are able to get covered. And then finally, we've got everyone else who, thanks to the individual mandate, should be getting health insurance. Now, there are a few exceptions to that, and we will go over that in just a minute, but that is it.
The Affordable Care Act also protects individuals from some forms of discrimination from people, women, for example, who might have previously had higher deductibles, higher co-pays because of their preventive services. And then here you see some more pre-existing conditions, eliminating time limits on medical care and co-pay requirements for domestic violence, birth control, and so on, to hopefully reduce costs for people with insurance.
Okay, I have a guest here with me to help me talk about the exemptions to the individual mandate. So this is Cece, and Cece doesn't have health insurance, but it's not due to one of these exceptions. So these are for people who don't need to pay the fine. And so the first exception is if the lowest price coverage available to you through either the marketplace or your employer would cost more than 8% of your household income. Then you don't have to get the insurance and you don't have to pay the fine. If you don't file taxes because you don't make enough money, and maybe if you've ever been a student, I know I've worked in the past as a student and didn't make enough money to have to file, and if that's you, you don't have to purchase health insurance.
And here you see some other options for exemptions. If you are uninsured for no more than 2 months, if you're between jobs or anything like that, you wouldn't have to pay the fine. If you would have qualified for Medicaid under the new federal definition, being 133% of poverty, then you don't have to pay. There are hardship exemptions and several other things that you can see by going to the website healthcare.gov. So what's the big deal about Medicaid expansion?
So what's the big deal about Medicaid expansion? It's important because the uninsured are not cheap. And when these individuals go into the emergency room or they need health care, the rest of us as a society or the hospital itself has to recoup that cost. So getting those individuals insured is important. There is a study here that showed there's a substantial decrease in uninsured community health center visits in states that have taken a part in the Medicaid expansion, whereas in these clinics that opted out, in states that opted out of the expansion, continued to have higher rates of uninsured visits. So getting these individuals out of the emergency room into their primary care will make a difference. However, the Medicaid expansion was deemed unconstitutional by the Supreme Court, and they stated that the Medicaid expansion is unconstitutionally coercive of states because states lacked adequate notice to voluntarily consent, and the Secretary could withhold all existing Medicaid funds. So basically putting states between a rock and a hard place, trying to force them into Medicaid expansion, it's not okay, said the Supreme Court. So now we have certain states that are participating and taking a part in the federal funds that are being given to them through the Affordable Care Act in order to expand Medicaid, but not all states are doing it, and it is causing a problem for those people who make 133% to the 100% of poverty.
So what's the impact of the Affordable Care Act on healthcare access, cost, and quality? So the healthcare costs have varied between 1 and 2.5% of gross domestic GDP. But we noticed that from 2013 to 2014, inflation for healthcare prices went down 1%. It went from 7.5% down to 6.5% for 2014. So with the fragmentation of the healthcare system, it's hard to know exactly how, what saved this, where these savings came from. We do see that savings have occurred. There's also an estimated 300 million uninsured individuals, or it has been estimated that there will be in 2017. This does represent a decrease from 2014 when there was approximately 44 million uninsured in the United States. Analysts have concluded that despite the Affordable Care Act's intentions, there will continue to be uninsured individuals, and the state and federal government will always incur a net cost. So the 10-year estimate right now puts that cost at $1,375 billion. So there's still a long way to go to really get those costs under control. And the benefits. We see, again, reduction in healthcare costs and the significant effect on spending, and the readmission penalties, which we mentioned before, trying to encourage hospitals and other providers to do a good job the first time and prevent patients from having to go back to seek additional care. So the Affordable Care Act has implemented a national pilot program, again we mentioned before, and trying to encourage hospital doctors and other providers to work together. So the idea in the past may have been that if you went in for a procedure, you might have had to pay a physician fee, a hospital fee, a radiology fee, and so on, each one individually. And the hope is that you may go in for something and just pay one lump sum that the providers then have to divide amongst themselves, which gives them some incentive to work together and together to reduce cost for that procedure. Here we see the percentage of adults in the United States without health insurance by quarter. This is a Gallup poll. And you do see that over time, that percentage of adults without health insurance has gone down. So, good things. Specific factors. The cost of the healthcare overhaul has been high, unfortunately, but the value to providers and consumers are there. And the risk to healthcare system implementation, with change, always there is risk that, there may be difficulty in the process. So all of these are factors in the implementation of the Affordable Care Act.
Okay, so let's talk about a couple challenges that the Affordable Care Act faces. The first one is we've talked a little bit about this high-risk pool and how we try to offset the high-risk patients by having more people, and so other people can help support that cost. But the other problem with this risk rating is that you raise costs for people who don't have that risk. So let's say, for example, you have people who smoke or people who drink. Some believe that if you have these cost-sharing insurance exchanges, that there's not as much incentive to lower your risk factors, like stop smoking and not drinking and reducing obesity. So that's one issue. The next one is the fraud and abuse. And so the Affordable Care Act has tried to address this a little bit by requiring facilities that participate in Medicaid to undergo these stringent regulations. But because of the vast number of providers and consumers, it's kind of difficult to monitor and verify payments for all of them. In fact, the FBI estimated that the fraudulent billings to both public and private insurance amounted to 3 to 10% of the total health care spending. So it's a lot of fraud and abuse, and that's one of the challenges the Affordable Care Act is going to face moving forward.
What's the future of the Affordable Care Act? Are we looking at being a good piece of legislation or bad? And providers are struggling to figure that out. A lot of them, with the onset of electronic medical record systems, are just watching to see what happens, whether or not they will continue to remain just in practice by themselves, or some are saying that they may merge into larger healthcare systems to reduce administrative costs that can sometimes be assisted by taking part in a hospital, for example, system. So as these providers wait, try to become more efficient, and watch what happens with the Affordable Care Act, a lot of things may change. And so if we can get things to become more, to reduce the health administration costs and become, as you can see here in the graph, continue to follow this baseline being lower than what the original estimate was, then that will be a benefit for the Affordable Care Act.
Hey everyone, so this is Moti, and he's going to help me tell you about the facts of the Affordable Care Act. In order for us to try to determine, is it a good piece of legislation? Is it bad? So first, in 2014, the number of uninsured individuals, or Americans, fell 25%. That's a decrease of 8 million people, leaving 11 million people still uninsured. 11% of adults with incomes over 250% of poverty, that's $29,175, still find it difficult to pay premiums to their health insurance company. So unfortunately, that's still a negative. That's still something that we're having to face. There's a 22% increase in the number of insurers for 2015. So that number of companies offering insurance, the hope is that that will continue to give competition. So these exchanges are encouraging groups to come out to participate, and Mochi likes that idea. Let's get more competition, right, buddy? And then of the 7.3 million who signed up for insurance through an exchange during the first enrollment period, 85% of those qualified for federal subsidies. So that says that the people who weren't insured before, perhaps due to cost, hopefully are getting insured now.
So here you see in 5 different studies, they did see that the percentage of uninsured Americans has declined. So those are all benefits to the Affordable Care Act. We also have the fact that 19 to 25-year-olds, the percentage there declined for the first quarter of 2014. It was 34% in 2010, down to 21%, and that makes it down about 4 million people. That 4 million people now have health insurance, and that's a great thing. A negative is the fact that hospitals have been hurt by Medicare payment cuts. They've put that out as $260 billion over 10 years. But they're hoping that, again, can be offset by the insured customers, the increased number of insured who can help pay the bills, make up for that loss. And the Department of Health and Human Services estimates that hospitals will save $5.7 billion in losses from the uninsured. But they note that 75% of those savings, about $4.2 billion, will probably go to the 25 states and DC that expanded Medicaid, saying that that Medicaid expansion will probably recover more losses, and the states that refuse to expand Medicaid will not see that money be recovered.
Thank you for watching this presentation. I hope you learned something. I hope you were able to develop some new ideas about the Affordable Care Act, and we will see what happens moving forward. Chances are it may be changed. It may not be the same in 10 years, but as long as we continue to evolve and create a better, more functional American healthcare system, then hopefully we will all be better off. So thanks again. Have a good day.